Now I request Dr. Sunil Kumar sir to present his topic. He is an associate professor at RIO, Rajendra Institute of Medical Sciences, Ranchi, and he will be talking about how to teach and enhance academic, clinical, and surgical skills.
Thank you. So very good afternoon, everyone. So the topic assigned to me is the teaching and enhancing the academic, clinical, and surgical skills. So I have no financial interest in any of the subject matter mentioned in my presentations. So the residency training is one of the most crucial phases in the medical career. It transforms the theoretical generalist, that is the MBBS, to a practical specialist, that is the MS ophthalmology in our case, who is geared up to take the responsibility of the caring for the patients. And so the acquisition of the knowledge and development of the necessary clinical and surgical skills is the prerequisite for providing the optimum care to the patients. So I have basically divided into three groups. PG training, the one is the academic, next is clinical and surgical skills. So coming to the academics, what is the most important? For the first year, for all the residents, you must make the habits of the reading books and journals. And it is not the one day, it is a daily effort which is required. You must read something every day. And if any interesting case you saw in the clinics or in the OPD, suppose you saw a patient of the Fuchs-Beatty syndrome, your senior or faculty might have made the diagnosis. So when you go back and so you read from the standard textbooks and match your findings with what is given in the books. And next day you can discuss again with your seniors. So in this way you will learn for a longer period of times. So the next question which comes to mind, especially for the first year resident, is which books to read. So in my opinion, don't restrict your readings. Your seniors or colleagues may comment like, "Arey, wo kyun padh rahe ho? Ye tum Ryan kyun padh rahe ho? Tumhe to Kansky padhna chahiye tha." But this is not like that. Believe me, you are allowed to do the wide readings. Any book which you like Ryan, Sild, Kretschmer, Jakovic, any book you should read. Why I'm telling that? Because in these books, the sentences or paragraphs are written in such a manner that you can retain more. So what are the basic reference book which you must read? In my opinion, the Kansky's Clinical Ophthalmology, the beautiful images are given for all the topics and all the chapters, and also the books from the American Academy of Ophthalmology, that is a basic and clinical science course, that is the 13 volumes, very concise book. You must have all these books. And also the Albert Jacobi, the Principle and Practice of Ophthalmology. I don't have any financial interest related to any of these books, but these are basic for the residency. Then there are also the specialty books, like the Retina, the Ryan's, Cornea by the Kretschmer, Smolins, Steinert, Cataract Surgery, Still textbook of glaucoma, Disease of the Orbit by Rootmans. Very beautiful differential diagnosis is given about the orbital tumors in these books. Also the strabismus by the Von Newdens and the refraction. I'm not saying that everyone has to read these books from the first page to the last page, but especially the common things you saw in the clinics or for the case presentation or seminar, you have to take the reference from these specialty books. Then there are hundreds of journals available, but for the resident, you must read the survey of ophthalmology, especially when you are making the seminar presentations. There are beautiful review articles are given from where you can get from the starting from the historical perspective to the current advances they are given. Also the current opinion of ophthalmology, the recent advances given. You can also take the reference from these journals. Now coming to the attending the lectures and seminars. So every teaching institute has their fixed seminar lectures, but coming blank to the class is a crime. So every resident who is coming to the class, you must read in advance. Because you know the teaching schedule and know the topic at least a week in advance. So you must read from the standard textbook. Make your own notes. And when you come to the class, not forget to ask the question. Also become the part of the discussion. So in this way, you will gain more. Also they're coming to the case presentation or the ward round. So in the case presentation or ward round, a resident doctor presents a patient history and examination before a faculty in the presence of the other residents. And the discussion regarding the lacuna in the history taking, examination, and possible investigation and management that follows the presentation is most rewarding. So always be active or always participate in this ward round. Whether you are correct or not, it doesn't matter. Always try to ask the question, why this investigation is done, why we are giving this treatment, why not that treatment. You should always discuss. There are also various PG teaching programs. Even the AIOC is the pre-conference PG teaching program, ISALA. The ARCs and pharma sponsored by the iFocus, by the CFS groups, IPAY by the LBPI. Even the various state society run their own PG teaching programs. So you must attend at least one of these programs. There are various online resources also available, like ONE network. If you are a member of the IOS, you can get access to this network. Also like helio.com, iWiki, or BSE Opta to mention some of these. And also the various lectures, beautiful YouTube channels are there. So you can have access to this. Now the next part is coming to the clinical skills. So again, for the clinical skill develop, daily effort and hard work is required. And you must make the habit of the comprehensive eye examination. No matter what the patient has come, even suppose the patient has come for just for the presbyopic correction, you should make the habit of the comprehensive examination, like visual acuity, Goldman applanation tonometry, slit lamp, 90-D examination. At least you try to see the disc and macula. So in this way, you will not miss the important diagnosis. Also, you have to do the indirect ophthalmoscopy and gonioscopy in selected cases. And also the investment. For the first year, you must purchase your own lenses on good quality lenses like from the bulk. I don't have any financial interest, but these lenses is worth of their price. Also, you should have your own direct ophthalmoscope, gonio lenses, retinoscope, so you can make more use of that. Now coming to the slit lamp examination. You must do the slit lamp examination with the proper technique. I am not going to detail about these things, because this is out of the scope of this, my presentation, but you must do the systematic manner, like diffuse examination to see the gross abnormality, lead and extra examination, then focal examination, retroillumination, sclerotic scatter, specular refraction, etc. And you also must do the staining pattern and make its interpretations. Then fundus evaluation, especially if you are in the retina clinics, do the direct ophthalmoscopy, indirect ophthalmoscopy with the proper indentation, and make the habit of the proper fundus drawing in the proper Amsler-Dubois chart. And also you can do the 90-D examination with the both dilated and undilated pupils. Similarly, the tonometry you have to do in each and every patient, and gonioscopy in certain patient, you must learn the practice. At least you have to do the one gonioscopy per day. That's why you can make the identify the angle structure, grading of the angle, and especially if there is any abnormal pigmentation or synechiae, you can make out. Now the refraction. Nowadays, many residents are reluctant to do the refraction, but in my opinion, refraction is one of the most important part of the PG training. You must learn the art of the retinoscopy, use of the Jackson cross cylinder, and also how to prescribe the glasses. Then biometry. Biometry, all the residents must do with their own. Like keratometry, manual keratometry, must learn AS scan, the immersion on contact method, and also you should get acquainted with the various formulas of the. You just not do that like the technician. You have to assess the various formulas. What is the axial length? What is which is matching with our AC depth or not? What is the lens thickness? And whether the IOL formula is matching with our preoperative refraction or not? And what are the different formulas which you are using? You must all be acquainted. And you can discuss with your seniors or even your teachers. Then there are various investigative modalities which are in some of you maybe in your departments, like fundus photography, fluorescein angiography, OCT, UBM, ophthalmic ultrasound, automated perimetry. So you must be able to interpret all the findings of these machines. Now the next part is the surgical skills. So the beauty of the ophthalmology is the sight restorative microsurgery. But this surgery requires lots of practice, hand-eye coordination, and ambidextrity. Ambidextrity is very important. And also you should get acquainted with the function of the microscope, like what is the zoom function, fine focus, centration, IPD setup. So before starting the regular surgery, real surgery, you have to get acquainted with all these functions of the foot switch. Now suturing. Suturing is again the vital ingredient of the ocular surgery and should be encouraged to the resident. They could start suturing on anything like thermocol, banana, you can practice apple or even orange, because this will help the trainee to develop good hand-eye coordination and also teaches the ambidextrity under the microscope. Now, for the first year, there are various minor surgical procedures which are specifically done by the first year. So you must learn like conjunctival and corneal foreign body removal on the slit lamp, syringing, probing, collagen incision. But you must learn the proper technique from your seniors. Biopsy of the small lid tumor, suture removal, tarsorrhaphy, subconjunctival injection, retrobulbar, peribulbar anesthesia, PST injection, artificial eye fitting, or evisceration like that. Now coming to the major surgery training, there are various phases. In the first phase, generally, or the first year, the PG student is given the training in the preparation of the cases for operation, pre-medication and the regional blocks. In the next phase, the PG student assists the operating surgeon during the operation. And in the third phase, the PG students operate independently, assisted by the senior residents or the faculty members. So the wet lab training. Wet lab actually is the building block of the surgeon's skill. It is an indispensable component in the armamentarium of the teaching hospital. It helps the trainee to develop the skill in a risk-free environment. So what we can do practice in the wet lab, like suturing with the 10-0 nylon in the thermocol or animal cadaveric eyes. We can practice the making the sclerocorneal tunnel in animal eyes. Even the practice the capsulorhexis in the goats or animal eyes. Use of the Simcoe cannula to aspirate the OVD after injection in animal eyes. We can use the goat's eye for doing phacoemulsification also, or the various wax model is also available, like from the Madhu instrument, eye phaco is there. Also, you can practice the placing the foldable or rigid IOL in the animal eye. And even the automated anterior vitrectomy can be practiced in the animal eyes. Now coming to the complication during training surgery. Remember, even the best of the surgeons today have made some mistakes while learning. However, since we are dealing with the human eyes, we cannot afford to make too many mistakes. Whenever a mistake is made, read up and discuss with seniors about it so that it is not repeated. So it is all right to make a few mistakes, but it is unacceptable not to learn from them. It may be helpful to record each and every steps of the surgery and review surgical videos in consultation with your senior in case of any complication. And finally, do not worry about the time taken during the initial surgery. Speed is never as important as the safety. So to conclude, the daily efforts, hard working and sincerity is what is required from the resident side, and practice to require the clinical and surgical skills. And of course, the good teachers and mentors required for your proper training. Thank you very much.
Thank you, sir, for the wonderful